Okay.
Right.
Okay.
Okay. Thanks everyone for joining us to the Scotland ITP patient group meeting. Once again, I have to apologise for the one I had to cancel at the very, very last minute earlier in the year, but these things happen, unfortunately. Thank you, as always, to Dr Catherine Bagot from Glasgow Royal Infirmary for joining us. Catherine will be here to answer any questions you have. We're also joined by our Senior Patient Advisor, Rhonda Anderson, and board member of the ITP Association, Derek Elston. And I noticed as well, we've got two of our local group organisers as well, Pat Conray and Sue Hussain from Edinburgh. Welcome, everybody. So does anyone want to kick off with the first question? Or should I? I've got one to read out, which I can. The Revelaid crib sheet says to have regular eye tests. How often is that? The crib sheet says that the doctor should arrange. Would that be down to the GP or the hospital side of the thing? Luckily in Scotland, we have free eye tests every 2 years. Should we be asking them to look for anything not included in a routine test? So,
oh, there's a question.
It is, isn't it?
Let me just have a think. I want to. What I can do is have a little look at the SPC.
Yeah.
The patient. The what's it called? Summary of product characteristics. I can probably try and do that during the meeting, and I can just confirm.
Okay.
So I mean, it's not something we massively worry about, and I suspect that a regular optician review is going to be absolutely fine. But let me just check so I can give you the right information about that.
Okay, great stuff. That's great stuff. I can remember years ago I was on one heart medication, and it used to create bits, floating across the eye, and I had to have an eye test every 4 months, I think it was.
Yeah.
But that was years and years ago. So, and I can't remember the name of it, but still, right. Rhonda, you've got a good question. Do you want me to read it out, or would you like to read it out?
No, you can go ahead and read it out. I just want to say before you do that, Mervyn, if you don't mind, we do have a guest here tonight. My guest, actually, Tina Harris, and she's on my PPG. And I invited all my PPG with permission from Mervyn to come tonight, but it was very short notice, so they couldn't come. But Tina has made it. So Tina is watching and listening to see what we do tonight, and you're very welcome, Tina, so thank you for coming. Yes, you can go ahead and read it. Thank you, Mervyn.
Okay. Right, a question from Rhonda. She was diagnosed with osteoporosis in her hips. Her mother had it, and also her sister. She's been having regular DEXA scans. She's going for infusion treatment as she has stomach issues for the tablets. As she has stomach issues for the tablets, the doctor says it may have been caused by the steroids that she had back in 2001. And I'm assuming that was when you had your spleen removed, was it?
Yeah.
Is that likely? Also, will the infusion have any effects on her blood and be a risk for the ITP?
Okay, so there's a few things in there.
Yeah.
So you're having regular DEXA scans, and Rhonda, you said you're having an infusion of something, because
I haven't had an infusion yet. That's what they're saying I should have, and that will be probably December. I go into the hospital and have it done, rather than having the injection.
Is that because of the results of the DEXA scan?
Yes.
Right. Okay. So I presume that's going to be something we call a bisphosphonate. Is that what they've said?
No, it's something xenozanimab or something.
Oh.
I think in Australia they have. My sister's having one called Prolo something or other in Australia, but I know they have all different brand names and things.
But it is for your bones.
Definitely, yeah. It's for building up the bones, which he says, the rheumatologist says, has happened because I had the steroids before 2001.
Well, yeah, so we definitely know that steroids can cause osteoporosis if you take them for a long period of time. And the DEXA scans are looking for specific parts of the body to see if the bones are weak in those particular areas, not fractures or anything, but just that the bones are thin. And we know that, you know, sometimes it can be simply improved and resolved by the use of vitamin D and calcium replacements, which really we recommend all people who are on now, who are on long-term steroids. So things like Thiacal, people might recognize that name, or Adcal D3. But sometimes if the osteoporosis is bad enough, then you need to move to something called a bisphosphonate, which can be taken as a tablet once a week. If anyone's heard of it, alendronic acid or alendronate, where you're told to take it once a week and sit up in bed for ages so that you don't get bad stomach issues. But you can also give those in an infusion. So I presume, Rhonda, that's what that is. And I mean, the one I particularly know the name of is Zamita, or zelendronic acid, but there are many types.
So do you think
there's something else?
Would that have any effect on your blood, having the infusion?
I think Catherine's
your ITP now, that's have any effect on your I wouldn't expect that to have any effect on your ITP at all.
Or on the blood generally. No effect on blood.
No. It's all about what these things do is they just they alter the mechanism of the different cells in the self, not in the bone marrow, but eat it up. So there are cells in the bone that are constantly remodeling bone. So a little bit of eating up, a little bit of making, and the bisphosphonate makes the cells that make bone more active than the ones that eat up bone. I'm talking about it sort of in very basic terms, but that's what it's trying to do, so that they're not thin. But unfortunately, yes, steroids, although they're brilliant, they do have their side effects, particularly when you take them for the long term. So generally we recommend anyone who's on steroids now takes calcium and vitamin D supplements, which, you know, as I say, they're often called Adcal D3 or Thiacal. They're all the same thing.
Yeah, I've done that. I've done all of that. It's just, I think it's partly genetic, and, you know, it's a lot of different things.
There's that as well. So yes, I should say everyone in Scotland should take vitamin D. Whether you take steroids or not, we're all due to the poor weather.
Yeah, and of course you don't get the sun in some parts of the year anyway, from April to September, no matter where you live in the UK.
I've got a question for you, Catherine.
A little bit complicated, I'm afraid.
Go on.
So I have beta thalassemia minor, which I've inherited from my father, having a bit of Asian blood around. And I always have an abnormal blood count anyway. But because I've just recently had seizures, I've been put on soluble aspirin, which I have to have for the possible strokes I've had, and levetiracetam. I'm going to the seizure clinic on Monday for the first time up in London. Should I mention this? Because I'm feeling pretty tired, and I've done a blood test myself on one of these little things, and I'm very, very low on iron.
So you've got beta thalassemia tray.
Yes.
Yeah. Which is you know, it's an asymptomatic condition, so you don't need to worry about any of these medications having an effect at all. So I mean, obviously you can mention it, because what will happen if anyone does a blood count on you, they'll see that your red cells are very small and very pale. So if they know ahead of time that you've got beta thalassemia tray, then at least they know what the reason for that is. Being low in iron, though, is something completely different. So being low in iron has nothing to do with the beta thalassemia tray, although it can cause the same changes to
there's certain foods, aren't there, that you could eat to help?
Yes. So are you low in iron?
Yes, but I do take, because I've looked into it some time ago, not an ordinary iron tablet, but I have started to take ferrous fumarate, which doesn't interfere with the thalassemia, doesn't knock out the red blood cells like some other iron tablets do. So whether I should carry on with that, I don't know.
I mean, if your GP's told you to take ferrous fumarate, then that's absolutely fine.
Just the soluble aspirin thins your blood out even more, doesn't it? But I've got to take it, and I've got to take the other one.
So the aspirin affects your platelets. It doesn't affect your red
Oh,
cells
the
at all.
platelets, what we're talking about, we're going to talk about, isn't it? The platelets.
Yeah. So aspirin interferes with your
Okay.
platelets. It doesn't interfere with your red cells at all.
Okay, right, okay. I'll write a note on that. Affects the platelets.
Okay.
Yeah, fine.
Does
Thank
that
you very
help,
much.
Tina? Yeah.
Yes, it does. I need some information to give to the.
Great stuff. Thank you. Right. Joseph had a question. You're on mute, Joseph. So. Always let the wife do it. That's it.
Okay. Can you hear me?
Yeah, we can hear you now. Go ahead, mate. Go ahead.
Hi, my name is Joseph. Now, I've been diagnosed ITP about 4 years ago. I tried all kinds of medication, and nothing seemed to be working. And it worked for a short while, then my platelets will go down. And now I'm waiting for approval to go on to what's that one?
Fostinitimab.
Fostinitimab.
Yeah, fostamatinib. Yeah.
I went for approval, and it's my last hope before I get my spleen taken out.
Right.
I'm not very keen. I'm not very keen to get my spleen taken out because I'm not convinced it will work because of my age. I'm 65 now.
Yeah. It's really, really tricky. Some people are lucky and ITP isn't a problem, and some people are really unlucky and ITP can be a real problem. And the very fact you're telling me you're going on to fostamatinib tells me that your ITP has been a real problem. So it's definitely when you're running.
His platelets at the moment just 12,000.
Right.
And so it has been problem for a few years now. It can't stabilize. It's always go high and then drop right low.
Right. And obviously it's entirely up to you whether you want to answer any of these questions. I mean, do you have bleeding problems?
No. Generally I feel good.
Right.
Just when my platelets get low, I get purpura.
Right.
And the bruises.
Yeah, and do you have any other bleeding, like gum bleeding or nosebleeds?
No.
Happened once.
Yeah.
Nosebleed.
And when you're not on any treatment at all, your platelets sit around about 12, do they?
Yes.
That sort of level.
No, he's on the treatment just now. He's on a 60 milligram of steroids plus Avantrobag.
Right.
And his platelets still 12,000.
Oh, right. That's really tough. That's really, really tough.
Last week it was 4,000.
Yeah. So I can see. So what we'll often recommend is that when a patient's, when it starts getting very difficult to treat ITP, we'll recommend that you go on to something like Avatrombopag plus. Maybe not prednisolone, but I can understand why your doctors are using that because obviously you're very difficult to treat, but you'll use a drug like prednisolone alongside something like Avatrombopag to try and boost your platelet count. But when that doesn't work, then things are getting quite tricky. So, and that's why your doctors are recommending fostamatinib. And I think that's definitely worth a try. It might not work, but it's definitely the right thing to be trying now.
Yes.
And having your spleen taken out is always a tricky one. About 2/3 of people respond to having their spleen taken out. So it can be really good, but we do always get a little bit worried, particularly as people get older, about the side effects of having the spleen taken out. Obviously, it's an operation in itself, but afterwards there's an increased risk of infection. If your doctor's spoken to you about it, you have to have vaccinations before your spleen's taken out to avoid some of these more serious infections that can occur more commonly if you've had your spleen removed. And they also recommend taking antibiotics after your spleen's removed as well. But also there's the sort of operation itself where there can be bleeding problems or infection as well, just having the operation. So if it works, it's great. I mean, if it works, it's fantastic. But if it doesn't work, you've had your spleen removed and not achieved anything. And that's always very tricky. The only thing I will say though about having the spleen taken out, and I've got experience of this, is that once the spleen's gone, and if it doesn't work, often treatments then can be effective. I've had a couple of patients where I've been amazed about that. And it sort of makes sense because the spleen is where platelets are destroyed in anyone, but particularly in ITP. And so you have a patient who's really, really resistant to all treatments. They get the spleen taken out, and that may work for a bit or not work at all. And when you try the treatments again, you sometimes find they're effective. Now, again, you know, I still say, though, having your spleen taken out is a big step. But if it worked, it could be a good step. But yeah, fostamatinib first, I completely agree.
So the treatments might work better when spleen taken out.
Well, that's my experience. I'm not saying there's sort of evidence out there to say let's take people's spleen out and then try the treatment again, but that is certainly something that I found. I've had people who've been so resistant to treatment and they have their spleen taken out and it works for a while, but then the effect disappears again. And then when you try retreating them in the hope it will work, it actually does sometimes. So it's just another thing to just mention that sometimes can happen.
Yes.
Joseph, was it your friend who emailed us the other day?
Yes, that was
Yes.
Grace Cummings. She's I work in a pharmacy.
Yeah, that's
and
it.
I'm
That's
the
it.
dispenser,
Yeah,
and she's
yeah.
a pharmacist.
I thought your story sounded familiar. Yeah.
Yes, yes, that's
Good
yes.
stuff. Okay.
Thank you.
Great stuff. Thank you. Rhonda, you got your hand up. I'm assuming it's about having your spleen removed.
It is indeed. Yes, Joseph. I have had my spleen removed in 2000. I was in hospital for 6 weeks locally. Tina will know Whipps Cross Hospital. And I was in for 6 weeks. When I went in, I had a platelet count of 0. They tried to do everything to me to get my platelet count up and they couldn't. Nothing worked. That's when, you know, you heard the earlier question. I was on steroids. I was on a double dose of steroids. I had been on steroids before that and I had insisted on coming off them. But then my count just kept going down and down and down. And remember that in 2000, there were none of these fancy treatments that you can have now. That was, you know, it was sort of, well, Catherine will tell me if this is wrong, but it was pretty much steroids, azathioprine, and splenectomy. But I did have it out and I was quite sick at the beginning and they did tell me it hadn't worked, but eventually it did work. And I was on the penicillin for quite some time. And then I also wanted to come off that because I didn't want to be taking penicillin for the rest of my life. And I've come off that and I've got emergency antibiotics that I take. I think you would probably have to take the penicillin for 2 or 3 years, but Catherine will put you right on that. And then you can just have your emergency antibiotics in case you have some kind of bacterial infection, which might unfortunately become an overwhelming infection, which you have to be very careful of. But usually, I mean, I think Catherine will agree with me on this point. It's a pretty drastic thing to take your spleen out, especially since there are now other treatments. But, you know, since you've gone down the road of these things, you might be at the point. But I don't have any particular problems with having had my spleen removed. I'm just very aware of the fact that I have to be careful not to, you know, get stuff really. And if I do, if I think I've got a really bad something or other, I, you know, consult my doctor or a pharmacist if I'm in another country, which I was once. So I've got my emergency antibiotics. Do you think I should take them? And they always say yes. But yeah, so, I mean, you can ask me any questions you want to, and I'll try and answer them if you want to ask me anything about that.
Okay.
Thank you very much. Thank you.
Okay,
yes.
great stuff.
Mervyn, can I
hold on one sec, Derek. I've got a question in the chat, which I will go to after Derek's had his question, because he's had his hand up for a while. Go ahead, Derek.
I'd like to ask you, Joseph, has your haematologist set you a level of platelet count that they would like you to have?
I think that counts.
If she said she'd like account the platelets, if she'll be happy with.
No, she's no very happy, but it's kind of stable, maybe above danger, maybe.
Did she tell you what level she would like it to be?
Or she 50.
50. Right. Yeah, I mean, 50 is great. 50 is fantastic. Anything over 30, I'd be happy with. We know that once it goes over 30, you're very unlikely to have spontaneous bleeding problems. But over 50, you can have major surgery and you don't have bleeding problems. So 50 would be a fantastic goal to have.
Yes. My main concern is I can't go to the dentist. I'm desperate to go to the dentist.
Oh,
I can't go.
Yeah. It's tricky that. I mean, it depends what the dentist wants to do. When you do have it depends what they want to do. You can use a medication called tranexamic acid to try and help with bleeding problems. But you wouldn't really be able to have any injections or scale and polish. But if it just was as a check, that would probably be okay. But you need to have teeth removed.
Yes,
Yeah.
But you don't bleed. Did I hear you say that you don't suffer with bleeding, spontaneous bleeding, just bruising and purpura?
No, bruising. Sometimes purpura.
And this is a really tricky issue, that, because when you don't have what we call wet bleeding, so bleeding in the mouth or bleeding gums or nosebleeds, then probably your risk of serious bleeding is quite low, because we know the platelets that you make, so the platelets that ITP patients have are very, very good young platelets, because they make platelets with no problems at all, but they're just broken down too quickly, which is why they're low. So it means that what's circulating around in you is very good quality, shall we say. So it's not uncommon for ITP patients not to bleed at all. And then you have patients who, like yourself, have bruising and purpura, and then unfortunately there are other patients who have lots of problems with bleeding. And when you have bleeding problems with ITP, then you really need to be thinking about a treatment really, really aggressively. But if you don't have bleeding problems, so nothing at all, or bruising, then there is always this balance between really fighting to get a normal platelet count with the side effects that can be involved with medication, or doing nothing at all, which can be a bit scary, but there is that option, particularly if you start getting to the end of the road where nothing's working. So as hematologists, we're really, really taught, and we do these days, concentrate on the patient's bleeding symptoms rather than the platelet count itself. So although your platelet count is 12, it's the bleeding that really matters. So if you're not bleeding, then this is good. However, if a dentist scuttled around in your mouth, that would probably be a different matter. So yeah, I think the dentist has to be on hold for now, unless it's something very urgent.
The doctor told me not to. They said the dentist not touch me.
Yeah.
We just don't understand. A few weeks ago, he was like 400,000 platelets, and then just dropped so rapidly. He can't keep stable. It's just high and low.
That's interesting, because that would suggest that the avatrombopag is effective. So have you been on this regimen of avatrombopag and prednisolone for a few months now?
No, just 2 weeks.
2 or 3 weeks.
All right. So
before he was on plate injections.
Right.
Romiplastin injection.
Yeah. And did the platelet count go up and down with the end plate injections?
Yes.
Or did it not work at all?
Well, it did work for a while, yeah.
And then it
looked like whatever he tried, whatever he's got a new medication, it worked for a short time, and then it's just stopped working.
That's very common. And I saw some heads nodding there. That's really, really common, that you show the body a new medication and the platelets respond, and then that tails off. It's really common that. So I think your hematologist will know you the best. And what you're describing is quite common in patients who are having trouble with their ITP, going through this and that and the other medication, responding for a bit, then stopping responding, and it's very frustrating. But the thing that I think you should be very reassured about is that you're not bleeding. That's a really, really good thing.
You know, that is really a plus point, isn't it, Catherine? You know, that it's not suffering from bleeding.
Very, very, very much so.
Yeah,
Very much so, because some patients can, and it's not that it's serious bleeding, but, you know, really suffer with, you know, if they cut themselves, you know, it won't stop and they'll end up with an enormous bruise, or they clean their teeth every night and they really have a lot of bleeding. And sometimes, you know, nosebleeds can be, you know, quite serious. So so it's really good that, you know, it's been 4 years and you haven't had any significant bleeding problems is very reassuring.
Thank you.
Okay, thank
The
you.
only thing I'd like to add to that, Catherine and Joseph, I had a count of 10 stable for 10 years, about, no medication, but I didn't bleed. I was very lucky. And I think, as Catherine said, that is the key point. But as regards the bruising, yes, I bruised terribly, but over a period of time, the bruising stopped. For no apparent reason. Didn't matter what the count was, the bruising stopped. So I think we're all different, but one would hope that that would happen to you if your count remains low.
Yes,
Thank you so much.
thank you.
Okay, great stuff, great stuff. Now, I just want to take this question first that Lauren put in the chat. She says her question is about a refractory case of ITP with underlying autoimmune disease, Hashimoto's and psychotic arthritis. She says, what treatments have seen the most success, and has a trigger for ITP been identified as any autoimmune phenomenon that could be curtailed? Now, as far as a trigger goes, interesting point, but Catherine?
Yeah. So so we know autoimmune diseases go together. So if you have one autoimmune disease, you're likely to have another.
Yeah.
So it's not necessarily so much that the autoimmune disease has caused the ITP to occur. It's a little bit more probably that your immune system has this tendency towards autoimmunity. So if you have Hashimoto's, for example, it's not necessarily so that the Hashimoto's has caused the ITP, but it's more that you have this autoimmune tendency. Now, sometimes it varies from problem to problem. But if we take rheumatoid arthritis, for example, or psoriatic arthropathy, sometimes when you focus your treatment on that thing, the rheumatoid arthritis or the psoriatic arthropathy, you can actually improve the ITP. Now, is that because, you know, you're suppressing the immune system to treat one condition and then that treats the ITP alongside it? It's difficult to know. But basically, we don't know what the trigger is for autoimmunity. There's loads of research being done in that area. We certainly know that there are genetic tendencies to autoimmune diseases, and that sometimes if you're, say, treating rheumatoid arthritis, that will often help the ITP at the same time, but what causes what is very difficult to know. But yeah, if you've got psoriatic arthropathy and then developed ITP or vice versa, I wouldn't find that surprising at all, unfortunately.
Okay, does that help, Lauren?
Yes, thank you very much. I don't know if you can hear me. I'm actually in the
yes,
hospital right
yeah.
now with ITP, so
Oh, shame.
apologies for not being on video. But this is, yeah, that is very helpful. Thank you.
No problem.
Thank you very much. Thank you. Right, I've got a question in chat, but first of all, Rhonda's got a hand up. I'll go to Rhonda. You're muted, Rhonda.
Yeah, this is just going back to Joseph. Sorry to jump around. But Joseph, when I had my splenectomy, I had a platelet count of 8. They said they'd do it. They weren't happy about doing it. They wanted my platelet count to be about 80 for a major operation like that. And when I had it, I mean, I don't want to frighten you or anything, but I mean, I think it's important to know the truth. after I had the operation, I did have quite a serious bleed because my hemoglobin went down to about 3.4, and I had to have a transfusion. And they did tell me that they might take me back to the theatre to open me up to stop the bleeding. They didn't have to do that, fortunately. But, you know, they will tell you these risks anyway, because whenever you have an operation, they go through the risks. And of course, I didn't know what was going to happen after the operation, but before the operation, you've got to sign. And I said to them, well, you know, what do I do? I said, have I got any choice? And they said, no, sign on the dotted line, which I did. And I had it and I recovered. But, you know, I'm sure you know with all of your history that, you know, there are drawbacks to whatever treatment you have, as Catherine has said. You know, everyone is different. What happened to me will not happen to somebody else. But it is wise to know some of these things. So I hope that's helpful.
Yes, thank you. Yeah.
Thank you very much. Right, before I go to Patricia, just the question in the chat leads me on to an email that just this second dropped into my mailbox from NICE. This is for the people on the call who are in England and Wales. They finally approved avatrombopag for use in England and Wales, which is good. You know, you people in Scotland have been lucky enough to have it available for what, the last year, Catherine?
Yeah, it's about that. It's about the turn of the year. Yeah.
Now, yeah. So it's been a long road in England and Wales, but we finally got there. So they've just released a statement now, which is excellent. And that leads me on to the chat. There was a question about that on the chat. Will avatrombopag make L-trombopag obsolete? I don't think so from what we've just said, because everyone's different. So, yeah.
That's a very, very interesting question, that. So, as I'm sure many of you know, with L-trombopag, you have to avoid dairy products for 2 hours before and 4 hours afterwards. You have to have your liver function monitored. And with avatrombopag, neither of those problems exist. So it means you can take the avatrombopag at any time of day, and there's not the same concern about developing liver inflammation. This is so true with avatrombopag that it is also recommended for patients who have severe liver disease who've developed a low platelet count as a result. So I don't know what NICE have said, but generally avatrombopag is supposed to be used after L-trombopag and romiplostim, or not so much that actually. Sorry, I should explain it a little bit better. Avatrombopag is not supposed to be used until you have chronic ITP, which means you should have had it for a year. Whereas
the guidance that they're going to publish on the 17th is for avatrombopag in combination for treating chronic ITP. Yeah.
And whereas romiplostim and L-trombopag, well, the goalposts have moved quite a lot actually, but basically you can pretty much use those second line now if steroids don't work, basically. So as a doctor, I shouldn't really offer avatrombopag to a patient until they've had ITP for at least a year, but it might possibly maybe be that maybe I might bend the rules very slightly.
Excellent. I know even in England, I know some people have got it on a, you know, these personal funding.
Yeah.
Claims. Yeah, they do. Yeah. So
I mean, L-trombopag is absolutely fine. L-trombopag and romiplostim are absolutely fantastic drugs. Absolutely fantastic drugs. Avatrombopag doesn't work any better than L-trombopag and romiplostim. It's just that L-trombopag has always been a pain for patients because of the diet, basically. That's the big thing. That's the big thing.
Yeah, I believe, you know, sort of looking back over, you know, the years we've been doing these virtual meetings now, the dietary restrictions of L-trombopag has always been an issue. With patients, always been an issue. Yeah. Right. Carmel, you got your hand up?
Hello, how are you?
Not too bad, thank you.
I'm joining from Ireland. My daughter has been recently diagnosed with ITP, so I'm very new to all this. And just interesting on the last comment there, Catherine, that you've made. She has only been diagnosed in the last 6 weeks, but her blood count was down as low as, in Ireland, we're only calling it 7, so I presume it's 7,000.
Yeah.
And 6 weeks of blood test, there was no movement. She went between 7 and 9, but she was put on tranexamic acid for 1 month or whatever, for a week in the month. But has been put on a course of L-Trombopag already. Would you find that very unusual?
No. So
she's
now
16, so she's neither a child nor an adult, if that makes sense. She's between both.
Yeah. So I just have to give a proviso here is that I don't treat children. Now I appreciate she's 16.
Yep.
So if I get any of the sort of guidance wrong in terms of cutoffs, I can't remember what the age cutoffs are for L-Trombopag, Romiplastim, and Avatrombopag. They may be 12 actually. Anyway. With children, I mean, obviously being 16, you're almost an adult, but basically children generally always do better with ITP than adults. So they often have no bleeding problems. It often resolves over time. Being 16, it's always very hard to know, well, are you an adult? Are you not? So it's really, really, really early days. So basically, is she under a pediatrician rather than an adult?
Yes, she is. She started when she was diagnosed. She was actually still 15, so she turned 16 in the last couple of weeks, and she has now been transferred to an adult hematologist away from the pediatric side.
Ah, right. Okay. So we're very much treating her as an adult. So basically, the hematologist has had to sort of say, okay, we're now 6 weeks in. The platelet count is still less than 10. I suppose the big question would be is whether she's having bleeding problems.
No, other than when she's on her periods, they've become extremely heavy. But no, she's no bleeding from the gums or anywhere else. No.
Yeah. So I suspect that basically the L-Trombopag is going to be started to see if we can get the platelet count up to a reasonable level, let's say above 30. And I wouldn't be surprised at all if after a few months, the hematologist may give her a trial off it. Because as I say, with children, it can often resolve quite quickly. They're much more likely to go into a spontaneous remission within the year than an adult is, appreciating that your daughter's 16. So no, I'm not. It's officially, if you are supposed to use prednisolone first, but I certainly wouldn't want to use prednisolone in a teenager.
Okay.
Sorry, joking aside, that prednisolone can really affect your mood. And it could make spots worse, it can make acne worse, it makes you gain weight, it gives you a really massive appetite, it can be difficult sleeping. So as I say, I don't deal with sort of anyone really under the age of 17, but it doesn't surprise me as a pragmatic decision to say, look, I've got a sort of older teenager who may be feeling a bit rubbish just emotionally anyway, because she's a teenager. And why don't we just try some L-Trombopag first line? So no, I mean, as the opposite side of that, I've had a couple of patients in their 90s who've developed ITP, and I haven't want to use steroids in them for sort of slightly different reasons. You know, they're sort of at the end of life, and you could cause delirium and more risk of infection. And so I actually went for L-Trombopag first line in those ladies, and it worked really well. So no, it doesn't surprise me. But I think the other thing I'd say is just ask your hematologist and say, you know, what do you think? Is this the right? Is this okay? You know, I've heard that steroids are given first time. You've gone straight for L-Trombopag. You know, I suppose the other thing is your daughter coping okay with the diet?
Yeah, she is. Yeah, she's just having to work around it, and that's it. Yeah, she is.
Yeah. So
not ideal, but look, if it fixes the problem, I suppose that's the bigger issue. That, you know, so far she hasn't had any spontaneous bleeding, but that's the worry. You know.
Yeah. And, you know, it's no fun having a really heavy period. You know, she's probably at an important time of her life when she's trying to, you know, do exams and all this sort of stuff. Yeah. So, yeah, it really makes sense to me what's been done.
That's fine. Thank you.
No problem.
Patricia, you got a question?
Yeah, I've got 3 quick questions.
Fire away, Pat.
You know, in the past, surgeons won't touch me unless I have a platelet count of 100. And now I'm hearing from some of you, it's less than that. That's one question. Then the other thing is, you know, I've had ITP for about 12 years and I'd always bleed a lot. And now for the last year, they've put me on Revelade electron pack. And so I haven't bled for a year. And now I'm up to about 60, which is great. And I wondered if there were side effects, because sometimes I feel like I'm going to lose my consciousness. But the other thing is, you'll be surprised, because I'm in America at the moment and it's 1:30 a.m. But here, if I had a whole year of Revelade, which I've had, now living here, I'd have to pay $68,000 for a year's supply. Now, it's very kind of the doctor here to give me enough to for the next 6 weeks, because there's no way I could be affording that. So we're so lucky with NHS that we don't have to pay these exorbitant rates. And I keep my health insurance in this country too. So I just thought you might like to know that.
Well,
so that's it.
Yeah, what a lot of interesting points you've made there. So first of all, I've got to say, go NHS. Now, just to reassure everyone, it doesn't cost as much as $68,000 for a year's worth of Eltrombopag in NHS, but that's partly because we can negotiate really, really good prices. So yeah, go NHS. Now, surgeons are a lovely bunch, but a funny bunch. So a platelet count of greater than 50 is what we use the term hemostatic. So it means that, you know, that is sufficient platelets to allow blood to clot when it needs to. And the problem is that there's no journal paper that's ever been published that sort of says that. This is all just from experience over, I don't know, 100 years. And so some surgeons, because they worry so much about bleeding, is that they won't do anything unless the platelet count is X. And as we were talking about before, it's not actually so much what the platelet count is, but it's whether the patient has any bleeding problems. So all I can do is give you an example that I don't actually do surgery, but one of the things that I sometimes have to do is lumbar punctures, where I put a little needle into someone very close to someone's spinal cord and take some fluids. Now, that is a very, very delicate procedure that is obviously, you know, it's not a big knife or anything, but if you get any bleeding in that area, it can cause really, really terrible neurological damage. Now, I would be absolutely confident and happy to put a needle into near someone's spinal cord with a platelet count greater than 50. I would have no concerns about it at all. Which is all I can ever say to a surgeon about, you know, a platelet count greater than 50. You can do anything. And in fact, when people go and have their spleens out when they've got ITP, we often have to do surgery when the platelet count is less than 50 because we can't get it up any other way. And, you know, often patients don't bleed. They can bleed, obviously, as Rhonda has said, but they don't always bleed. So it sort of has to be negotiated. If your platelet count is greater than 60 or is sitting at 60 with Eltrombopag, I would recommend that your hematologist speaks to the surgeon and reassures them that it is safe and that platelets in a patient with ITP are really, really good platelets. I think it's all about communication and reassurance. And I think, you know, the surgeon giving you that, your hematologist giving you that advice and support to your surgeon would be very helpful. For example, if I was your hematologist, I would write to the surgeon and say, I would be confident that a patient with ITP with a platelet count of greater than 50 is safe for any form of surgery. The only proviso to that is if you're going to have brain surgery. Then, although again, there's no evidence base for this, we've always been very, very worried about brain surgery, again, because bleeding in that area is so critical, is that generally we aim for a higher platelet count. But standard surgery greater than 50, we would be completely happy with.
Okay, thank you very much, Pat. Rhonda, you got your hand up?
Yes, I really want to ask Catherine this on behalf of Joseph. would it be helpful for Joseph to have an indium scan, or do you not do that anymore? Because I know that they, you know, I know you've got to have a platelet count of a certain level. So if you don't, you can't. So because I couldn't have had it because my platelet count wasn't high enough. They got it up to 12 at one point, then it dropped back to 8 from 0. So, I mean, has that been discussed, or could Catherine comment on that, please?
Sure. So so just to explain exactly what this scan is. So there's some evidence that if you do a test, a sort of X-ray type test to see where the platelets are being destroyed. So generally on the whole, platelets are destroyed in the spleen, which is why taking your spleen out should make a difference. But actually in ITP, if you do these special scans, sometimes you find that the platelets are taken up quite a lot in the liver, or a bit in the liver and a bit in the spleen. And so it was thought, well, if we do one of these special scans and see that the platelets are taken up by the liver, then let's not take the spleen out. If we see they're all being taken up by the spleen, well, then that means that taking the spleen out will work. If they're taken up by both, well, who knows? So basically what happens is that you have a blood sample taken in that sample of platelets, and they label those platelets with a little radioactive little molecule. And then they put those platelets back into you and see where they go. Pretty much as simple as that. And they scan your liver and your spleen and see where these hot platelets, if you like, have gone. Now, there's a few things about these scans. Some people swear by them and say, oh, absolutely, you have to have a scan before you have your spleen taken out. Part of the issue with this, I think if everyone had these special scans on their doorstep, then fine, you know, then we could get one done. And if it's part liver, part spleen, or all in the liver, we could sort of say, well, you know, we're not quite certain it's going to work. But these scans are only available in a very, very, very small number of places. So you can get them done in Aberdeen, you can get them done in, is it Newcastle or Sheffield?
It is Newcastle, I think.
It's in Newcastle, and London. My feeling on this has always been that if you're getting to the stage where you need to have your spleen taken out, then if you've got, let's say, a 70% chance of it working because the scan has demonstrated that it's all taken up by the spleen, or you've got a 30% chance because it's predominantly taken up by the liver, it might still be you want to go for that 30% chance because you're absolutely at the end of the road in terms of treatment. Now, when we were doing splenectomies much, much earlier in the pathway, I think there was a lot more to be said for doing these scans. But now, if I have a patient who I'm thinking needs their spleen taken out, it's really not going to matter where these platelets end up because we've reached the end of the line. We've come to a decision. The only option we have now is to take the spleen out. So I'm not a fan of them because I think the only time I think it's helpful is if it really matters to the patient, where they're sort of saying, well, I'm not prepared to take a 1 in 3 risk for a splenectomy, but I am prepared to take a 2 in 3 risk with, sorry, I'm saying that wrong way around. I'm happy to just have that chance of it working of 30%, or I'm not happy to take that chance for only working 30%. So you do the scan and sort of say, well, look, it's all being taken up by the spleen. It's much more likely to work, or it's predominantly being taken up by the liver. It's not so likely to work. And the patient may say, well, I don't want to have my spleen taken out because it's all taken up by the liver, or now I'm prepared to have my spleen taken out because it's all being taken up by the spleen. So, but I just think we're now taking spleens out in such a late stage of the disease that you're prepared to take that 30% chance if it is mainly taken up by the liver, because that's what you're talking about. It's much more likely to work. It's much more likely to work if the platelets are predominantly taken up by the spleen, but it's not that it won't work if they're predominantly taken up by the liver. It just means taking the spleen out is less likely to work. So your hematologist may or may not recommend it. It's tricky. It is tricky. You've really got to think about, will the result of that scan help me in my decision to have my spleen taken out? That's where I think it's important now these days.
Thank you, Catherine. Right, we're in the last 5 minutes.
my God, these meetings always go so fast.
I know, and they fly by, don't they? Fly by.
Now, the lady, I don't know if you remember this, Mervyn, but I had to do some homework following the last meeting.
Oh, yes, you did. The very
I
first
did,
question.
and I did
yeah.
my homework as well. And some people who were at that meeting are at this meeting, but the lady who I think asked the question isn't at this meeting. Is that right? I can't remember who it was.
I can't. No, I can't.
So shall I say what I found out?
Yeah, please, yeah.
Okay.
Yeah.
Unless anyone's got any burning questions. So basically the question is what did I think about the research into microbleeds on the brain? Which I didn't actually know what was being referred to. So
the question I believe was from Diane at the time. I think Diane White. Yeah,
right.
Yeah.
So this is what I found out. So there's research being done in London, in Hammersmith Hospital. Really, really interesting work. So basically, we know that we don't know the whole story. As we've touched on during the meeting, is what matters. Is it platelet count? Is it bleeding symptoms? Is there any way of working out who really needs treatment and who doesn't, particularly if you're becoming resistant to treatment? So the work that was done in Hammersmith was basically taking a group of patients with ITP and a group of patients who didn't have ITP and doing these very, very special MRI scans looking for microbleeds. And they tried to match the patients to being about the same age, because we know that as you get older, these microbleeds do get more common. And what they found was, it's really interesting actually, what they found was that people who had ITP for longer, who'd had lower platelet counts and who had more bleeding symptoms were likely to have the most of these microbleeds. So what the conclusion is that microbleeds in the brain may predict how likely someone is to bleed and therefore how likely someone is to need treatment. What the authors make really, really clear, so these microbleeds are completely asymptomatic. They're tiny, they don't cause any symptoms. They're absolutely tiny. You can't see them on a normal MRI scan, which is, if anyone's ever seen an MRI scan on the TV, the images you get from an MRI are really, really detailed. So you can't even see them on a normal MRI. What the authors feel is that this is another tool to try and predict who might be at risk of bleeding. Now, it only has a role in research, and this is very, very early days, but that's what it showed. And the authors made it also really clear that they're not saying that these bleeds are what causes the brain fog and the fatigue that sometimes ITP patients can experience, but that it may be a way of determining who's at risk of bleeding and who isn't, which I thought was very interesting. So if I'll have to make sure Dan maybe listens to this recording.
She will, and I will speak to her tomorrow for you. So,
okay. Yeah. And the final thing I just wanted to say, actually, because at one point when we were speaking, I looked up about the having your eyes checked.
Oh yes, yes.
So common symptoms are actually just dry eyes, itchy eyes, that sort of thing. But something else that's common is what they call loss of visual acuity. So you can't see as well. So basically, and there's no recommendation of how often you have to get your eyes checked or anything like that. So I think getting your eyes checked just regularly by your optician is all you need. But if you notice that you feel your eyesight is changing, then go and see your optician sooner. I think that would be absolutely plenty. My suspicion would be is that people notice a change in this visual acuity, how well you can see, possibly because they've got dry and itchy eyes. So, so I suppose the thing to bring to everyone's attention, and I'd forgotten this actually, is that if you do get dry and itchy eyes, it might be due to your L trauma pag. So yeah. I mean, the thing is with all medications, they all can cause minor side effects, and I can't remember all the side effects of all the medications that I prescribe, and often have to look things up. So a patient will come to clinic and sort of say, I've got X, Y, or Z. And sometimes you have to look it up and see if it is related. So yeah, so dry and itchy eyes.
Thank you very much, Catherine. Right, I think we're closed there, I think. Thank you, everyone. Just a couple of bits to sort of say before we do close. Anthony put it in the chat earlier. This video will actually be, I believe, our 90th video on our YouTube channel. So that there's loads and loads and loads of information on that channel from all the meetings that we've had over the years. So if you need to find anything, just watch, you know, some of the videos. Also, we're pleased to say that whereas the last 3 years we've had virtual conferences, conventions, next year's is going to be in person in London at the Royal College of Pathologists. Tickets are on sale now, and we're also going to have at that meeting a nurses forum meeting as well, which is being led by a nurse consultant from Bart's, Louise Taylor. So any nurses you know that you know of want to come, they actually get a discount on the ticket price as well. And also Derek Elston is going to be leading a business meeting of the International ITP Alliance at that meeting as well for me. So thank you very much for that, Derek. So it's going to be a busy day. So if you can make it, go to our website and you can register for tickets. They are going really, really well. We're already up to 90, I think it is, and they've only been on sale a couple of weeks. So, you know, we're getting there. So thank you, everyone. Thank you, Catherine, especially. Thank you, everyone, for taking part. See you again in the not
Sorry
too
about the
distant
internet
future.
connection.
That's okay. Thank you. Thank